Hello, my name is Ram Vaidhyanath. I'm a consultant radiologist based at the University Hospitals of Leicester. The aim of this talk is to introduce you to head and neck imaging. The extracranial head and neck includes the orbits, paranasal sinuses, dental structures, the skull base, temporal bones, as well as the soft tissues of the neck. So we'll look at some key anatomical structures of the orbits, sinuses, and temporal bones. Review some clinical conditions and how the clinical issues guide us towards appropriate imaging. Some common pathology, and end this talk by imaging of the head and neck cancers. We routinely use CT and MR in the orbit, sinus, and temporal bone context. Ultrasound is very useful to look at the soft tissues of the neck, and is more useful in image-guided procedures. PET-CT in the cancer context, and rarely do we use isotope scans. Let's start with the orbits and the visual pathway, starting with the anatomy. The visual pathway starts anteriorly in the orbits and extends all the way to the higher centers in the brain. So we'll look at some key anatomical structures and some common pathology here. Soft tissues of the orbits quite nicely nestled within the bony orbit here. A 3D illustration. However, on imaging, we will look at them in a cross-sectional manner, meaning axial, coronal, sagittal, oblique, what plane you choose to. So that's important, that this is not going to be a 3D representation as we saw earlier. The layout of my talk will include anatomy to start with and pathology. And when we talk of anatomy, the illustrations will be on your left, normal anatomy on the right. When we talk of pathology, these images will be on the left and the pathology on the right. This is a midsection going through the orbits, showing the lens, globes, optic nerve, the extraocular muscles, the canal into the pituitary fossa. Turn it into a coronal plane. This is going behind the globes. So we see the optic nerve, the muscles, superior middle, superior oblique, medial rectus, inferior rectus, and lateral rectus, both on MR as well as on CT. Note the intimate relationship with the brain itself, thus the anterior cranial fossa, the brain, and the sinuses. And all these are important when we are imaging a patient with orbital pathology. Superolaterally within the orbit is sat the lacrimal gland, an almond-shaped gland that is seen quite well on a CT here, and on a coronal plane, both on CT and MR, you can see that kind of extent of the gland itself. The illustration here shows the vascular anatomy, the internal carotid artery branching off to give the ophthalmic division, and the smaller branches within the orbits. Posteriorly, as we move towards the orbital apex, the cellar region, that's the sella turcica, hosting the pituitary gland, and that's quite well seen on an MR image here. The pituitary stalk and the optic chiasm, the junction of the optic nerves. Lateral to the pituitary gland is the paracellar region, and this contains the cavernous sinus, the important structures here being the internal carotid artery, and not to forget the important cranial nerves that traverse through the cavernous sinus. This is the oculomotor. This is cranial nerve 4. This is V1, that's the ophthalmic division of the trigeminal. V2, the maxillary division, and more medially is 6th abducent. See the relationship to the sphenoid sinus more inferiorly. Important cranial nerves that connect to the orbits. One of them is the oculomotor nerve, which supplies most of the extraocular muscles we have seen already. And this is a nice T2 weighted image of the oculomotor nerve starting at its nuclei in the midbrain. These are the cerebral peduncles, cisternal segment going towards the cavernous sinus and the superior orbital fissure. Interpose that with the vascular anatomy of this region, you can see the internal carotid artery, the posterior communicating, the communication between the anterior and the posterior communication, the basilar, the top of the basilar dividing into the posterior cerebrals here. So this is the circle of Willis, and you can see why we are looking for a vascular cause when a patient presents with acute third nerve palsy, and we'll see some examples later. What are the clinical issues we commonly deal with? Trauma is a big group. Proptosis, unilateral or bilateral, visual field defects, and lower down that order, cranial nerve involvement. When we're looking at pathology involving the orbit itself, we tend to deal with these patients using a CT. And it's visual field defect. When we want to look at the whole visual pathway, we tend to use MR. Let's start with trauma. This is an young lad out for a few drinks on a Friday night. He's punched on his face, and the force of the trauma has actually opened up his whole floor here. So this is a classic blow-up fracture, fracturing the floor of that orbit, allowed the herniation of the orbital contents into the maxillary sinus, and it's also entrapped the medial rectus muscle. Sorry, the inferior rectus muscle. It's not difficult to see that the patient presents with diplopia and a restricted upward gaze. That connection to the sinus means air within the orbit, orbital emphysema, and the blood can track down into the maxillary sinus, producing this fluid level. We always look for other fractures, and in this case, there is a fracture of the medial wall on the other side. Proptosis is another big group that we image quite regularly, and one of the common indications to image patients is thyroid eye disease. Proptosis itself is a clinical diagnosis, and what imaging is helping is in diagnosing what's the cause for that proptosis. Could be unilateral, could be bilateral. So thyroid eye disease involves thickening of the extraocular muscles. These are the normal muscles, abnormal muscles, and they follow a certain pattern. This is the inferior recti, the superior rectus, the medial rectus, the superior rectus, and spares the lateral rectus. It involves the belly of the muscle, and it does not involve much of the tendinous insertion, and this pattern is very classic for thyroid eye disease. What it also does is stretching that optic nerve, causing compression, and this is another reason why we scan patients. Young patient with visual problems, and when we do an MR, we can see that focal thickening within that right optic nerve. There's a contrast enhanced images. There's not much of enhancement here, but in the clinical context, this is a optic nerve glioma. Different patient, you can see that the nerves again thickened, but this shows enhancement, not only on the right side, but also on the left side. So we got bilateral optic nerve involvement. Not only the optic nerves are involved, more posteriorly, you can see the hypothalamus, the midbrain region, showing this enhancing lesions, all part of that optic pathway glioma. This lesion is compressing on the posterior third ventricle and is causing early hydrocephalus here. So patients with optic nerve glioma not necessarily would present with visual problems, can actually present with problems related to increased intracranial pressure. Different patient, elderly, and has got a right-sided proptosis going on for a year or more. Clinical examination shows a firm superolateral mass on the right side. On imaging, this is a CT, you can see that soft tissue mass. The lacrimal gland is not seen separate, so the inference is this is a lacrimal lesion. What the lesion is also doing is thinning that bone there. This is what we call as fossa formation, which also tells us that this is a slow-growing, more benign process. Compare that to the bone on the other side. Patient with a long history and this clinical and radiological features, we would think in terms of a lacrimal benign mixed tumor, also pleomorphic adenoma. This information is important to the clinician because they would excise the lesion completely rather than do an incisional biopsy. Bilateral lacrimal enlargement is seen. The differential includes lymphoma, sarcoid, and Sjogren's syndrome. You've seen the pituitary gland and the normal gland on to your left. And this is a patient presenting with the bitemporal hemianopia, and I've got a large pituitary mass here. The pituitary gland is not seen separate. The lesion extends superiorly or suprasellar, if you like, and compressing on the optic chiasm. It's also going inferiorly into the sphenoid sinus. Laterally, the internal carotid artery is still preserved. There are no aggressive symptoms here, and in the clinical context of bilateral bitemporal hemianopia, this picture would fit in with the pituitary macroadenoma. Lesions arising from the cavernous sinus or involving the cavernous sinus usually present with multiple cranial nerve involvement. And that's not surprising because we have already seen the nerves traversing through the sinus itself. This is a patient presenting with painful ophthalmoplegia, very acute presentation. And when we do an MR, we can see that abnormal enhancement within the right cavernous sinus. Compare that to the left, where the enhancement pattern is normal. You can still preserve the internal carotid artery flow void. And this is a classic example of a Toulouse-Hunt syndrome. This is entirely reversible. Patient receives steroids, and follow-up imaging, you can see that the right cavernous sinus becomes quite normal. Different patient. This has been going on for some time. They've got visual problems, and clinical examination shows involvement of cranial nerves, and this patient had involvement of 3 and V1. big enhancing lesion in the left cavernous sinus or involving the cavernous sinus. You also see some telltale signs. This is the dural enhancement here, and it's also extending towards the brain itself. It's all extra-axial. The imaging picture is that of a meningioma. We talked of that connection between the brain and the orbits via the oculomotor nerve, and this is a patient presenting with acute, painful right third nerve palsy. We do an MR imaging, which includes an MR angiogram. This shows a large aneurysm, which is compressing on the optic, the oculomotor nerve here. Not sure how well this projects on the screen, but this is where you would expect that compression. Different patient with a history of leukemia, presenting with cranial nerve palsy. Clinical examination had a third nerve palsy. MR with contrast shows enhancement of that whole cisternal segment of the third nerve, and this is a perineural disease secondary to leukemia. Moving on to paranasal sinuses, we'll start with anatomy as always, and this is an overview. You can see the representation of the ethmoid maxillary sinuses. The drainage pathway we'll talk about a little later. Close relationship to the orbits as well as the skull base and the brain, and lower down the dental structures. CT is a workhorse in investigating sinus disease, and this is a normal CT showing good pneumatization of the sinuses, maxillary, ethmoid, and the drainage pathway here. We always look at it both on a bone and a soft tissue window setting. The drainage pathway of the sinus is the most important thing in the context of sinusitis. This is what the surgeon wants to know. What's the state of the drainage pathway? Is it obstructed? Does it need surgical intervention? So we look at it more closely. The osteomeatal complex refers to the drainage pathway of the frontoethmoid and the maxillary sinus. So through the ostium infundibulum into the middle meatus. Posteriorly is the sphenoethmoid recess, which drains the posterior ethmoid and the sphenoid sinus into the superior recess. So the drainage pathway is the most important bit in sinus imaging. What are the clinical issues? Nasal obstruction, postnasal drip, headaches, facial pain, they present in a very different fashion. Query sinusitis is not an indication for imaging. The reason for imaging is to look at anatomical variants and to give a roadmap to the surgeons. So this is a patient with recurrent Rhino-Sinusitis. So normal. You can see that complete opacification of the left maxillary antrum extends towards the ostium. It involves the middle meatus and the ethmoid sinus as well. So CT is also showing the close relationship to the floor of the anterior cranial fossa and the dental structures. The next big group of Sino-Nasal Polyposis. These are polyps, mostly allergic, that arise within the nasal cavity and block that pathway. And the sinus disease is secondary to that obstruction. You can see that complete opacification of all the sinuses as well as the nasal cavity. And this is a classic example of an allergic Sino-Nasal Polyposis. The next bit we'll look at is the temporal bone. And what we're looking in particular is the petrous and the mastoid segments of the temporal bone. Overview here, starting with the pinna, external auditory canal, tympanic membrane, middle ear with its ossicles, malleus, incus, stapes, oval window, inner ear with the vestibule, semicircular canals, and the nerve itself, nicely shown on this graphic representation. This is my favorite slide, which shows the complex anatomy of this region in relation to the cranial nerves. Quickly, this is the sixth cranial nerve, 7, 8. We have seen that already. This is the glossopharyngeal 9, vagus 10, spinal accessory 11, and the hypoglossal nerve going below the neck of that eagle there. CT lends itself quite nicely to temporal bone imaging because it contains mostly bone and air, and the details are quite good. And it's what we do routinely, a multi-detector CT. And on a CT, this is an axial plane, the mastoid air cells nicely pneumatized. Bit of the ossicles here, this is the ice cream, the cone ice cream view. So the ice cream is the top, the head of the malleus. The cone itself is the body of the incus. On a coronal plane, we see some more critical structures. The scutum, which holds on to the tympanic membrane, not very well seen here. The space between the scutum and the long process of the incus, called as the lateral epitympanic recess or the Prusak space, and this is where you would expect acquired cholesteatoma in adults to happen. So this is the pars flaccida type of cholesteatoma. It extends more in towards the attic. You can see the roof of the attic, which is the tegmen here, and very close to it is the lateral semicircular canal. We've been very fortunate to have cone beam CT in Leicester for the last couple of years. Cone beam CT is very similar to the regular CT in terms of using radiation. The way the images are acquired are slightly different. What it allows us is to look at bone and details, particularly of dental, sinus, and temporal bone structures very well. And this is a normal patient. Again, that kind of cone ice cream view shown nicely. The malleus, incus, the incudomalleolar joint, the long process of the incus, stapes towards the oval window. And this is one big area where I like to use cone beam CT is the stapes oval window complex. Moving to the inner ear, starting with the CT anatomy, we've got the CP angle here, the cerebellopontine angle, and through this traverses these nerves. On top is the facial nerve, which enters the internal auditory canal, goes through the labyrinthine segment, takes a turn, which is called the genu, and bend, and goes down towards the tympanic segment. The tympanic segment is quite important in the middle ear disease situation. You can see that relationship here. The other key structures are this is the vestibular cochlear nerve, and we'll see that on an MR a little later. This is the vestibule, the lateral semicircular canal constituting the bony labyrinth. This is an heavily T2 weighted MR imaging, very similar to the one we saw the oculomotor nerve. What we're using is the MR properties. The CSF is very bright, the nerve is dark, and if we can see the whole nerve, we know pretty sure that that's normal. and this is used quite routinely in the screening for patients with question mark vestibular schwannoma. So the facial nerve anteriorly, the vestibulocochlear nerve going all the way, the cochlear nerve going into the cochlea. This is the vestibule, and quite nicely shown. And between the MR and the CT, you can see these structures very well. What are the clinical issues? We deal with ear discharge quite routinely. Could this be otitis media? Can there be a cholesteatoma? Cholesteatoma again is a clinical diagnosis, and what we're looking for on imaging or the complications of cholesteatoma. When we go into hearing loss itself, it gets into three big categories: conductive, mixed, sensory neural, and we'll see some examples. Normal coronal image, this is a cone beam CT, external canal, scutum, you can see that quite nicely aerated mid-ear. Compare it with this abnormal one. There's a lot of opacification, and that's caused blunting of the scutum, ossicular erosion, and if you go a bit more posteriorly, you can see that dehiscence of the tegmen, which means that this disease can easily enter the middle cranial fossa. Also note that the thin wall between the lesion and the lateral semicircular canal, and it's only a matter of time before this patient develops a labyrinthine fistula. Patients with cholesteatoma undergo surgery, and some of them come back a little later with recurrent discharge. So this is a patient 2 years down the line after their surgery, and when we do a CT, you can see that opacification within the mastoid cavity. There are no can't see much of the mid-ear structures here. We know that this is a post-op case. Is this recurrent cholesteatoma? Is this granulation tissue? It's quite difficult to say. Clinically, it's quite difficult to say on an CT as well. This is where we use diffusion imaging, and diffusion imaging has been in vogue for nearly 25 years. Has been used extensively for stroke imaging, and its role has expanded as we've kind of seen over the last 10-15 years. In cholesteatoma imaging itself, it's used particularly to look at residual or recurrent cholesteatoma. And when we do diffusion imaging, you can see that bright spot, the light bulb, which corresponds to the abnormality we have seen on the CT. In this patient, we also gave some intravenous contrast because there were some questions about the state of the dura and its relation to the middle cranial fossa. And again, cholesteatomas do not enhance, granulation tissue will enhance. So a combination of these features tells us that there is a recurrent cholesteatoma and this needs to be dealt with. Patients presenting with mixed hearing loss have a very classic audiometry picture. And just to reiterate the anatomy of the stapes oval window complex, you can see the stapes with the cruder footplate there, and this quite dense bone here is called as the fascia antefenestrum. And this is an area we look for in this condition called otosclerosis or otospongiosis. Cone beam CT image in a patient with otospongiosis, otosclerosis. You can see the plaque, the demineralization of the fascia. There is involvement of the anterior crust of the stapes. The footplate is thickened, and all this fits in quite nicely with the diagnosis of a fenestral type of otosclerosis. If that demineralization extends all the way back towards the cochlea, as is seen in another example, this is called as a retrofenestral type of otosclerosis. the stapes superstructures seen here beautifully on cone beam CT. Patients presenting with sensory neural hearing loss, vertigo, dizziness, usually undergo a quick MR image, which is the T2 weighted imaging. This is a screening technique I talked about. If you can see the nerve quite nicely, we kind of move them on to a clinical follow-up. But in this patient, there's a big mass that is sat there, which is extending from the internal auditory canal into the CP angle. And we recall this patient's first contrast imaging, and contrast confirms that this indeed is a vestibular schwannoma. When the lesion is small, they can be followed up clinically and on imaging. When it gets bigger, would need intervention with a gamma knife or rarely surgical. The last bit of my talk will highlight imaging in head and neck cancers. This is not very exhaustive, it's just very quick examples of cancers of the upper aerodigestive tract. So this is the nasopharynx, the orientate, that's the maxillary sinus, the turbinates, postnasal space. This is where the nasopharynx is. This is normal, and this patient has got a large mass sat within their nasopharynx. The role of imaging is not in diagnosis, but in mapping the extent of the disease. We want to tell what's the how far the tumor has gone. Is it involving the skull base? How laterally? Is there nodal disease or the distant metastasis? So in a way, we're giving a radiological staging. Oropharynx, quite common, more common than the nasopharyngeal types of tumor, and increasing incidence. You can see the normal palatine tonsil here, and then abnormal left tonsillar mass. The surgeon can see the mass on nasoendoscopy. What they cannot see is the deep extent of the disease, and also the nodal status as well as distant metastasis. Oropharyngeal cancers have a huge propensity for nodal metastasis, which might actually be the presenting complaint of a neck mass. We also kind of stage it with CT to look at distant metastasis. Hypopharyngeal cancers are rare, and when they do present, they are quite advanced. Again, anatomy. This is the laryngeal side of the airway, the aryepiglottic fold that divides the larynx and the hypopharynx. And this is the piriform fossa. Compare it to the abnormal one here. This is a patient presenting with pain in their left throat, difficulty in swallowing, and an examination there is pooling of saliva here. And not surprising, that is this enhancing mass involving the left piriform fossa, and better seen on the slightly lower image. Also note the enlarged lymph nodes. Some of these lymph nodes are not really big by size criteria, but the way their enhancement or the irregularity tells us that they are involved. PET-CT, we use them to stage primary cancers, especially the larger ones, T3, T4s, and this is a large tongue-based cancer. Very well seen on an MR image, and this was already a T4 disease. What the MR didn't tell us was the involvement of the lymph nodes, what we thought was normal-sized lymph nodes. And when we do a PET-CT, the primary lesion is seen quite well, but it did light up one of the lower lymph nodes. This is the lower bit of the cricoid cartilage, so this is right lower in the neck. The implication here is if we did not include this in the radiation field the patient would receive, we would not get good results. Patient will come back with recurrence. And lastly, ultrasound. I think it's very good to look at soft tissues of the neck, and in the cancer context, we're looking for these lymph nodes, neck masses. If you confirm that this neck mass is a lymph node, very easy to put a needle into it, get a quick answer. This is a fine needle aspiration. All we use is a blue or a green needle, take some cells, send it off, quick answer. And we know that we are dealing with an cancer here. Want a slightly bigger sample. In this patient with suspected lymphoma, we would perform a core biopsy, and you can see the whole length of the needle within the gland itself. And I have to thank my colleague Amy Barnes for these lovely images. So we looked very quickly at the imaging anatomy of the orbits, sinuses, and the temporal bones, some clinical issues, common pathology, and also how we would image a patient with suspected or followed head and neck cancers. I'm very grateful to Professor Richard Wiggins from Utah. He's been very kind to share all these illustrations with me and made my job easy. Thank you very much for your